Our next patient is a 78-year-old male with spinal stenosis. Of course, he doesn't want to take anything. You've had to convince him to take any drugs, and he's taking about 3 hydrocodone acetaminophen compounds a week. And that's only with prompting from his daughter. Never calls in early for refills. So your office just implemented a new drug testing policy, and he gets tested. It's negative for hydrocodone. It's negative for anything. And you call the lab to confirm, and when they confirm it, they find, yep, nothing shows up in the urine. The patient says he took his last dose about 12 hours prior to coming in. So what do you do with this patient? Michael, how do you take care of this?
Well, I think the first thing to remember is that these tests all have a threshold for detection. And he's on a relatively low dose with infrequent use. And so the first thing to consider really is that he is taking it, but it's just not reaching a concentration that triggers the positive test. So it is important to understand with the lab and the person that you're talking to when you confirm that result to know whether or not they see anything at all in the test or whether it is absolutely zero. And oftentimes you can get that additional information to tell you where you are in terms of the threshold. But, you know, there are other situations that could result in this. I mean, it is entirely possible that he is not taking the medicine. It may be that he is forgetting to take the medicine, and this is an age range where you've got an increasing rate of dementia, delirium, just normal forgetfulness. We know the average person doesn't remember to take their medicine like they should. So I think it is important to ask the patient in more detail, what are you doing and what is happening? How do you remember to take your medicine? On what type of schedule? What techniques do you use, like pill boxes? I think the other thing to consider on the more nefarious side of the equation is that perhaps someone in the family or some friend of the patient is taking their medicine. And so he may not be diverting it actively, but he may be a victim of coercion or threats to supply medicine to someone who has an addiction problem. The other possibility, we always discuss this, and it's difficult to really document, and that is that the patient might be a rapid metabolizer of the medication. And so compared to the average person, he is going to go through that medicine in a much faster fashion.
And he's not really taking it that often during the week, so your typical patient that may be taking 8 a day of the hydrocodone products, they're going to be exposed to that over and over and over again, and they likely are going to last in their system a lot longer than that 12 hours, whereas in some patients, especially the rapid metabolizer, they may not show right away.
This is a wonderful case of that brings the harmony of the office. You know your patient, and this is a good case of knowing the patient. You are implementing a new policy. And again, what Howard said, this is not really to go after the patient, it's just to help the patient. So when we have a lot of population of those patients that we see, this is for us to see if there's other drugs that involved in the urine drug testing. We are not really just to see, we know that coming to the test and patient telling us he's only taking 3 tablets a week, we know that it's going to be negative. This is where the story becomes an help to our cause. The patient is not calling any refill, so I will get more of the good side that yes, he is taking it as prescribed, 3 about a week, 4 a week, not calling any refills. So I will continue to write it. I did my due diligence. I did the documentation. I did the urine drug screen. He seems to meet compliance. We know that there's a cutoff for the urine drug screen, which is not going to show that he is taking the medication. But I know the patient. I know the family. I think I feel comfortable. Continue. Nobody can fault you with this. The problem would happen.
And I just want to point out one thing that you're bringing up, and it may be a little subtle, is so that the screen is negative. And if you don't document in the chart that you've looked at it and say, gee, it's negative because it's been 12 hours since his last dose, he takes it irregularly, it looks like he's not using it correctly. So the fact that you point out, but you need to document that in the chart, that you have an explanation for why it came out negative, as opposed to just ignoring it and figure, well, I don't want to write anything. I'm sorry, but
that's
keep
right.
going.
Well, this is exactly where documentation comes. The other side is when this is coupled with that the patient is calling for early refills, or a family member is calling for early refills, the urine drug screen becomes negative consistently. That's where the suspicion that comes. So this is all comes back to the point why urine drug screen is a tool to help you manage your patient, not only just we're going after the patient. This is becoming part of the management of the patient, not only just part of the testing as well.
Howard.
Let me make 2 points. Everybody on the panel made the point of the threshold of where lab reports it positive or reports it negative. And you have to know that, let's say, 300 nanograms per deciliter is reported positive and 299 is reported negative. So again, it's very important if you have unexpected results to call your lab. And we use the word screen in our terminology here on the panel. And we have to realize that screen denotes immunoassay as opposed to a chromographic test of gas chromatography, mass spectrometry. And immunoassay is very unreliable to pick up a semi-synthetic opioid such as hydrocodone, hydromorphone, oxycodone.
Especially somebody's taking it as infrequently.
Well,
too,
if they're taking a bath of it, immunoassay is not unreliable. It doesn't pick it up in a reliable way.
Bill, can I just make one other point? Because I think that we focus so much on the test result and how to interpret it and how to respond to it, but I always want to come back to how is that patient doing? If this is a patient who is saying the medicine helps me and my pain is under good control, that's very different than if this patient might be saying to you, I'm still in pain, the medicine doesn't help, I'm not doing well. And in fact, if he's not doing well because he's not taking the medicine, for whatever reason, it may be as simple as the side effects, the constipation that results from opioids, then this is a way to facilitate the conversation, to build the relationship,
absolutely,
and to get back to that teachable moment that Howard referred to.
Absolutely.
And in this particular patient, was one of my patients, they had a granddaughter had recently moved in with him, and he was becoming less functional despite still calling for his medication, and the granddaughter was taking his medication, and he was afraid to say anything about it. So
you were doing the urine drug test on the wrong person.
Should have been doing it on her, but it brought up the fact that it made me look at the situation again and see, now what is this new person in the family doing, and how do you handle that? Now he's less functional due to the abuse or the use of the granddaughter. That's just terrible, but it happens. Once again, something figured out with a urine drug testing tool. I want to thank the panel so much for helping with this very difficult discussion today.